Thank you to everyone who's joining us for our second session of PPHA's Public Health Webinar Series. We're so excited to be joined by Linnea and Teacher Kunda, who will be telling us about the Allegheny County COVID-19 Vulnerability and Inequity Tracker. If you have any questions throughout the presentation, please post them in the chat. There'll be time for some Q&A at the end, and I will go through them. This meeting is being recorded and will be posted to our YouTube channel at the end of the presentation. And without further ado, I will let them get started on their presentation.
Thank you, Brooke. My name is Teacher Kunda Mangono, as Brooke just mentioned. I am a program manager at Sego Ventures, which is a global US-based nonprofit where we use data science, AI, behavioral science to bring precision to solve public health problems as well as social problems. Specifically, I lead our TB India portfolio as well as our US COVID-19 analysis for projects such as this one, where we partnered with the RAND Corporation. My colleague Linnea from RAND is here. We also partnered with the Black Equity Coalition, as you can see on the slides presented there. We built this tool particularly to investigate some of the vulnerabilities across Allegheny County. And I will walk you through specifically what challenges we were solving and then how we went about building this tool. But essentially, it's one of the very interesting things about this work is that we collaborated with two other organizations. We're both working at national and local level, and there were different aspects to this that make this work particularly interesting that we're going to walk through. So without further ado, I will introduce our work. So this work is on what we're calling the ACCVIT, which means Allegheny County COVID-19 Vulnerability and Inequity Tracker. So what we're going to talk about today is going to be very simple in terms of the overall agenda, and then we'll get into the details for each of these sections. So we're going to walk through the motivation. Why did we do this work? Why is it important? How did we frame it in terms of the key questions that we were addressing? Then we're going to walk through the actual solution, how we got about to collaborating towards the solution and what the web tool presents or represents in terms of a framework of approaching vulnerability for COVID-19 at a local level, particularly within the county and within specific neighborhoods. We're also going to have a walkthrough. Linnea is going to walk us through the actual tool, how to use it, who uses it, and the insights that we've got from this tool. And then even more importantly, I think, are the recommendations of, so, okay, now we know, and we have this tool, what do we do, how do we use it, and what are some of the examples of the gaps that we can close when it comes to COVID-19, specifically at the local implementation level, which is what we are looking at when we talk about Allegheny County. So the motivation and context for this work was really inspired when we looked at what the COVID-19 situation was looking like as COVID-19 was spreading in 2020. When you look at the press releases that were coming out for COVID-19 at that time, you will see that we started seeing several press articles confirming racial and geographic disparities, particularly at national level as well as state level. But then there was nothing really at other local levels, specifically at the county level. And even if you wanted to go even at a more local than county, which is neighborhood or census tract or community level, there were not a lot of data sets that were investigating how different communities were being impacted by COVID-19 and which specific factors made them vulnerable and how they had access to different resources. So as we're seeing this rise in cases and these apparent disparities, there was a lack of granular data. And the overall result of this is that this masked the heterogeneity that you were seeing of the problem of COVID-19 and its effects at the local level. So that's our main challenge. So we looked around as Sego Foundation, as Sego Ventures, as well as the RAND Corporation and Black Equity Coalition. Unfortunately, we had two enabling factors that allowed us to move forward with this work. The first one is Sego Ventures CCVI data. So CCVI is a Community COVID-19 Vulnerability Index, which is an index that tracks how well a community is able to weather the effects of COVID-19. It goes down to the census tract level. So this gives us a picture of vulnerability of the community. We also, from the RAND Corporation, found that the county was putting out this data on COVID-19 tests, COVID-19 cases, and COVID-19 hospitalizations and deaths. So we decided to explore this by having a project that uses these data sets to allow us to focus on neighborhoods in Allegheny County. The overall goals of the project were to explore the relationship between Allegheny County in Allegheny County as our case study, relationship between vulnerability, as in the CCVI, as well as COVID-19 outcomes at the local scale and over time. Secondly, we wanted to model the association between physical distancing as well as outcomes in terms of testing and deaths. And then finally, we would be able to have some recommendations of identify the specific recommendations and gaps based on this work on what the outcomes were, access to resources, as well as access to being able to physically distance. So once we had these project goals, we decided to break it down into specific questions, which we asked ourselves. The first one being, which counties in Allegheny, which neighborhoods and communities in Allegheny County are the most vulnerable? And we had the CCVI to be able to guide us in this respect. We also asked ourselves whether each community had access to the resources that they needed to intervene in terms of COVID-19, specifically COVID-19 testing. How was testing access distributed across each different geography? Then we looked at what cases, hospitalizations, and death rates were they experiencing, as well as whether they were able to physically distance and how physical distancing can be modeled to see how it was affecting their outcomes. And finally, of course, as we mentioned, there were gaps that we wanted to identify and end up with specific recommendations for the county level, for the community at large. So what was our solution? Now that we had a good framing of the problem, specifically how we frame it in terms of the objectives and key questions that we were asking ourselves as we're going through this conversation, we were confident that we had the data to see this project through. And the key question now was, how do we go about it? There were 3 partners involved in this work, as I mentioned, Sego Ventures, RAND Corporation, and the Black Equity Coalition. And I just wanted to explain to you how we all came together and what the role of each organization was, as this sort of represents a good partnership model that can be followed in terms of skills needed, capacity needed, and the end product that you can expect when we put our heads together to look at data and challenges at the county level. So Sego Ventures, as I mentioned before, is an action tank, a nonprofit that is solving social and public health problems using precision. So bringing precision using data tools, data science, behavioral science, as well as AI, and making sure that we look at the customer who is the patient seeking care, or the person who experiences a symptom of a particular disease, as the core of our model. Then we have the RAND Corporation, which looks at policy issues. RAND is a research organization that is developing solutions to public policy and challenges. It's a big organization that operates at both local and national level. The Black Equity Coalition is a group of experts and community leaders that are supporting the creation of equitable systems, really by focusing on how do we affirm the dignity of every human being, and their key aspects to achieving this are collaborating, networking, and policymaking. And we'll see that a lot of the advocacy work that they did to get some of this work to come through. So in addition to the 2 datasets that I mentioned, which are the Sego CCVI dataset, which is the vulnerability index, as well as COVID-19 testing cases, deaths, and hospitalizations at the county level, we also had some complementary datasets that helped us get a much more comprehensive 360-degree view of the problem of COVID-19 and how it was affecting different communities. And these were datasets that had to do with mobility data in terms of how people were moving around during the pandemic and during lockdown. This came from SafeGraph. We also had Allegheny County test site data, location maps, which told us where each testing site was, what were the characteristics of that testing site, when were they open, We also did some interviews at the local level through the RAND Corporation to specific actors in the COVID-19 intervention at the public health sector to figure out exactly how things were working on the ground, right? Things may be listed on a website to say that the operations are open from 9 to 5, but sometimes we actually found that this was not always the case. And facilities were operating maybe at half capacity and everybody was overwhelmed. So these were some things that we actually had to go to the ground to figure out how things were actually working. And we incorporated all that analysis into this tool that we're going to present to you. We also looked at survey data, American community survey data, which told us the characteristics of different neighborhoods, population, demographics, and dynamics. And then we had another data set which allowed us to do qualitative interviews of test sites and talking to health workers about their actual experience on the ground and at the forefront of the dealing with the pandemic. So you can see that we actually had a very comprehensive collaborative view, a comprehensive set of data sets that allowed us to have all the different views at very granular level within the community. And you can imagine all the views that you can create. And Linnea my colleague will walk you through some of how we encapsulated all of this in the ACCVIT web tool and all the highlights that we get from this tool. So before we move on to talking about the actual tool, what it looks like, who uses it, and what we found in our case study, I wanted to just take some time to talk about the underpinning data that we used in this work, which was Sego Ventures COVID-19 Community Vulnerability Index, which tracks, it's an index that's indexed from 0 to 1, and it tracks a metric of vulnerability across the US in different communities, all the way down to the census tract level. So you can look at the county, you can look at the state, but also at the census tract level. And that's one aspect that allowed us to then reaggregate the census tract level to the neighborhood and to the community level. Because when you talk about census tracts to the layperson, people don't know that's just a number. So we wanted to actually say, this is what's happening in your particular neighborhood so that people can relate to the tool that we have. And you'll see when we walk you through that, we're actually trying to capture a bigger audience, not just researchers or public health officials to be using this tool, but we also wanted to have the layperson use this tool. So we had this vulnerability data set. And the way we built it is that you can have this view of the map of the whole US, and you can categorize it from low, very low to very high, depending on which, if you look at different quantiles of that 0 to 1 metric. One thing I wanted to mention is also that this was not an index that just came out of thin air. It's actually built upon the CDC's Social Vulnerability Index, which some of you may be familiar with if you've worked in the sort of disaster or pandemic or public health space for a while. So what we did is we improved this metric by adding some COVID-19 specific and specific health factors that are really specific to COVID-19 and not necessarily about general vulnerability. So by doing that, we then made it a very specific indicator. And the way we developed it is that we actually look at 40 plus specific indicators. So for example, access to transportation may be an indicator. Population that is over 65 may be an indicator. And so we have 40 plus of those. And then we group them into factors that we thought made sense based on our research and literature review that made sense in terms of categorizing it for risk or vulnerability when it comes to the pandemic. And you can see all these categorized into 7 key factors. First one being socioeconomic status. Like, do you have the money? Do you have a job? Are you employed? Like, what's your social status in terms of like class and employment status? Household and transportation. Do you have access to transportation? Minority status and languages spoken. Can you speak the language? Do you have access to the resources, which can actually, language can be a barrier sometimes when accessing resources. Epidemiological factors, which is a big one. We looked at systemic healthcare system factors, as well as whether you live in high-risk environments or population density, which turned out to actually be a very big indicator of spread of COVID. So these are all sort of how we came together to bring this very comprehensive data set, looking at vulnerability at each community from the lowest level, the most granular level to the state level. And this was the underpinning solution for the data that we then started analyzing and built the tool. So this is the why and sort of the what in terms of the problem and how we approach the problem. Now I'll pass on to my colleague Linnea from the RAND Corporation, who's going to go through the solution, walk through the tool itself, and discuss some of the findings. Linnea, over to you.
Great, thanks so much, Titch. So I'm Linnea Warren May, and I am a policy researcher at RAND in our Pittsburgh office. And I do work on community health and resilience, and I just love having the opportunity to work on local projects like this one. And as Titch mentioned, I will be talking through the tool we built and what our analysis found. So given the wealth of detailed and timely data that we had available on vulnerability and COVID-19 testing and outcomes for the county, as Titch just presented, we wanted to make a tool that could layer all of that information and help a variety of users make sense of it. So we all are probably familiar with COVID-19 dashboards that are available at the county and state levels, even the national level, but we really wanted to build something that was super usable and kind of could walk people through the data. So the Allegheny County COVID-19 Vulnerability and Inequity Tracker, ACCVIT, is a web tool that presents visuals updated weekly with live data alongside a digital narrative to tell the story of COVID-19 vulnerability and inequity in Allegheny County. So as Titch mentioned, I'll actually walk through the tool shortly so you can see it live, but as a quick summary of the type of information it provides, we provide a set of maps that show neighborhood and municipality level vulnerability based on the CCVI and case counts. We show cases and COVID-19 outcomes by race. And we show testing and test site data, including test site access correlated with community vulnerability, as well as test positivity by race. And then finally, we also conducted an analysis of the ability of communities to practice physical distancing by community vulnerability, as well as the impacts of physical distancing on COVID-19 testing and death rates. So that's just quickly the high level of what the tool shows. And yeah, so who is this for? Who is interested in this type of information? So we envision this could be useful to a variety of users. Local policymakers might find it useful to inform the expansion of testing locations, helping them to identify communities of greatest need or who are expected to be at greatest risk during the pandemic. Leaders of community-based organizations could use the tool while making decisions about where to locate vaccination clinics or center vaccination campaigns with a consideration of communities experiencing vulnerability. So this tool, as Titch mentioned, and as you'll see, is really focused on testing and test site access, but we thought there could be a lot of important learnings for vaccination access as well. So you'll hear us mention that a few times. We also thought that policymakers from peer communities could actually learn from our process of developing this tool as they try to advance their own commitments to an equitable COVID-19 response. So, you know, folks have dashboards, they have various ways of showing the data and presenting it. And we thought this could be an example of how to collect and analyze relevant data that breaks down this information by race, ethnicity, and other demographic and community factors. And then, of course, residents who are interested in their community's COVID-19 status could learn about the state of their response in their community, and that could inform their own decisions, you know, individual behaviors, what they want to do for their family safety, or even their advocacy efforts through neighborhood organizations or other ways that they are engaged in the community. So if you could go to the next, thanks so much. So now what you've all been waiting for, I want to take some time to actually show you the functionality of the tool from a perspective of a hypothetical user. So imagine that I am a chief equity officer at a large health system covering most of the county. And I have heard that COVID-19 is disproportionately impacting residents of color in my community, but I really need more information to share with my stakeholders, with my board, to inform how our system can work to address disparities in COVID-19 in our community. So I'd have a few questions that we think that this tool could help answer. So first, what is the state of racial disparities in COVID-19 testing cases and outcomes? And then how can my system's efforts help to close gaps? So for example, can we provide additional mobile testing, maybe think about more convenient hours, more community outreach to encourage testing, more support for physical distancing? There's a lot of different ways we might approach helping to close the disparity, and we would want some information to inform that. So now I'm going to open the tool. So Titch, I'm taking over screen share from you. And I will walk through what it actually looks like and how a user could view this information. So hopefully you now see the tool. So I'm going to explore it from the perspective of this Chief Equity Officer. So I open the tool and I can see that I can navigate to the information that I need via a sidebar menu that shows the various headers within the tool. But I actually want to take a look at the research highlights first, just to kind of get a general sense of what was found. So I will scroll down a little bit to that section on research highlights. And I see that Black residents are more impacted by COVID-19 in my community across the board, it looks like. So I actually want a little bit more detail on those data. So I'm going to navigate to the cases, hospitalizations, and deaths section of the tool. So I navigate there through the sidebar, and it pops down to this section. And I'm looking at these visuals and I noticed that cases across races peaked in the winter months. So that's something we all probably are aware of. And that cumulatively, Black residents shown in this yellow line have experienced the most cases throughout the course of the pandemic. So scrolling down, I also notice when I'm looking at the health outcomes section of the tool, that they also disproportionately experience negative health outcomes. So hospitalizations, ICU admissions, ventilator use, and deaths all seem to be higher cumulatively amongst Black residents than residents of other races and ethnicities. So my question now is, what can I do about this? How can I implement some interventions to help to address this? So I'm interested in how testing might play a role, since my health system conducts COVID-19 testing. So I'll scroll down to the access to testing section of the tool. And I'll actually pause here because I don't think I mentioned that we'll make the URL available. So anyone who wants to take a look at the tool and play around with it, you'll have access to that after. But hopefully this is a nice little orientation to what you can do with it. But anyway, back to the role of the Chief Equity Officer. So I look at this map of site locations for testing, and I notice the orange dots are located actually pretty well aligned with communities experiencing higher vulnerability. So the dark blue and the teal areas of the county. So I can at least let my stakeholders and partners know that we're doing a pretty good job in terms of locating testing. But my concern is about racial disparities. So I'm going to scroll down a little bit to see what testing looks like by race in our community. So these two panels show the positivity rate, so the percent of COVID-19 tests that are positive over the course of the pandemic, as well as the number of tests that are conducted on a daily basis by race. So I noticed that first, there's been a lot of fluctuation in test positivity over the course of the pandemic, and also in daily tests by race. So it's really useful to know that I can get this on a regularly updated basis moving forward. I also see that while more testing is conducted for non-white residents, white residents are shown in this purple line here, over the course of the pandemic, positivity rates are still running higher for Black residents and other racial and ethnic groups, even in the recent months when our positivity rates have been pretty low. So I think there's probably more work that my system can do to help to mount an equitable response that might start to tackle those positivity rates, other than just providing access to test sites. So what are some other barriers in access to testing that we might tackle? So this tool also gives me a little more information on the other barriers that our research found. So, I noticed that there are some issues with the hours that testing is offered. Maybe there's ways we can support more mobile or at-home testing to encourage more folks to be tested. So I think that those are probably some solutions that I might want to pursue as I'm thinking about our strategy. So if I'm thinking big, or if I'm another type of stakeholder, I might be interested in what we can do to support physical distancing, which is shown in some visuals further down the tool. I'm not going to get into that right now, just because it's a little bit more afield from our example, but certainly invite you all to explore these features. And there's also a number of other mapping features and more of the narrative I didn't have time to walk through. So certainly explore the tool on your own to get a sense of all of that. So I'm actually going to jump back to my slides if you want to start sharing your screen again, Titch. That would be good. Okay, great. So now that you've gotten a sense of what the tool looks like and how a hypothetical user might use the tool, I want to talk through some of the key insights from the work. So as our main top line finding, which I shared with you during that last example, we show that Black residents in Allegheny County test positive and are hospitalized from COVID-19 at higher rates than white residents. A second key finding is that overall, the COVID-19 positivity rates in Allegheny County are slightly exceeding the WHO recommended threshold, which is sort of a benchmark that a lot of communities are using of 5%. So our average positivity rates have hovered around 6%, though, as you saw from the charts, has been very highly variable over the course of the pandemic. And now we're running lower than that benchmark, but with a slight uptick in recent days, unfortunately, due to the Delta variant. More cases or more tests per capita have been conducted for Black residents than for white residents in Allegheny County, which is actually a departure from national patterns. So that's a good sign. This is suggestive that local efforts on the part of our partners like the BEC and others have been responding to the racial disparities observed in COVID-19. Similarly, available testing sites are actually located near communities that experience the highest vulnerability to COVID-19. So again, there was a lot of work done early in the pandemic to partner with FQHCs to site COVID-19 testing there. And that was a strong advocacy push that has shown to be pretty useful in order to provide folks with higher vulnerability access to testing. And then finally, we demonstrated the importance of physical distancing initiatives, which isn't something that I specifically walked through, but we found that when physical distancing is occurring, it is associated with lower death rates, especially among communities that are most vulnerable to COVID-19. So it was a disproportionately beneficial intervention to enact physical distancing or to allow communities to physically distance. However, residents in higher vulnerability communities are also less likely to be able to spend more time at home, primarily based on employment patterns and other factors. So now I want to talk a bit about some of the recommendations that came out of our work so that folks who are in decision-making authority can take some action based on these findings. So firstly, I think the main thing we learned is that this project was really only as good as the data we had access to, which is actually pretty great. It was a pretty robust data set. So it illustrates the importance of routinely accessing and monitoring disaggregated data related to racial inequity and geography, since the impacts of the pandemic are different across populations and communities, and this is changing rapidly over time. This was a critical contribution of our partners at the BEC as they advocated to have this data available by race ethnicity and to make it publicly available after they had to do a lot of data scraping by hand from state systems early in the pandemic. So we, again, are blessed with a wealth of data disaggregated by race, and a lot of communities in the United States don't have this at present. And so it's really hard to mount an equitable response if you don't have that information. Secondly, given what we saw about the differential ability to physically distance, we recommend providing greater assistance to help those who are most vulnerable to COVID-19 to practice physical distancing and use mobile testing so that they can receive testing while also reducing community transmission. Thirdly, in order to keep equity top of mind for decisions moving forward, as unfortunately the pandemic is dragging on, we suggested appointing an equity-focused executive governance panel to provide continuous expert advice and feedback on critical issues and interventions as they emerge. And then finally, as we've noted a couple times, this work was completed over the winter months and was really focused on testing. We also thought that there could be best practices learned from testing access to inform equitable distribution of and access to vaccines. So while again, this is really about COVID-19 cases and tests, vaccination is certainly still top of mind for many of us, and this could offer some important learnings. So with that, we wrapped up at about half an hour. So that was pretty efficient. So I just wanted to, I guess, open the floor for questions. You'll see here, Titch has posted a link to the tool itself and more information on the CCVI, they're available here. And I think that they should also be available in the chat, at least the link to the tool. But yeah, happy to answer your questions. And Titch, I guess you and I can just kind of pass back and forth depending on what the nature of the questions are.
Yeah, definitely. And Brooke, yeah, feel free to moderate the questioning.
Yeah, thank you so much for that presentation. We have one question already from Miriam. Where is the data from? So what are some of the data sources for this project?
Yeah, so I can start with the local data, Titch, if that works. So the data on COVID outcomes and testing is from the Allegheny County Health Department. So they scrape state systems daily and update that on the Western Pennsylvania Regional Data Center. And so that's where we get that. The other data, Titch just navigated to that slide that shows the other data sources, but we got the information on the CCVI. Sergo had developed that, so we already had access to that. There's a company called SafeGraph that uses cell phone data to track mobility, and that's what we use to show physical distancing. And we also found test sites from the sources that Titch described from GIS Core, and then some ground truthing on our part, as well as the qualitative data that we found.
Yeah, and there were a lot of data sets also even behind these top 6 or 7 that we are highlighting here. So for example, if you remember, I mentioned for Sergo Ventures CCVI, we have 40 plus indicators, and those were all about housing and transportation, socioeconomic status, language and minority status, health and epidemiology, systematic health aspects of how much does the government or does your location spend on health. So there are so many other different data sets, and we can actually provide that if you're interested in doing that. And of course, the biggest source for data is also the CDC's SVI, which also pulls from population census data. So these are all official data sets that have either been used by others before or are coming from reputable companies.
This is fantastic. Thank you so much. Yes, I'm Miriam. I'm an MD student at Penn State College of Medicine, and this is really wonderful work. So thank you for sharing it. In regards to that question, I noticed on one of your initial slides, you mentioned a headline that said, if I remember correctly, it said something like 70% of data, I don't know if it was hospitalizations or COVID-19 cases, were not recording race or not reporting race. And was that a challenge for you in this project? And how did you get around that? And do you have any recommendations for someone who will be hopefully working in hospital systems in the future in regards to that?
Yeah, great question. I can start, Titch, and you can jump in if you have anything to add. So we were lucky by the time we started looking at the data, it had become a lot more complete, but that is not by chance. There was a lot of advocacy effort on the part of the BEC and other stakeholders to encourage systems, testing providers, everyone entering data into state health systems to record race and ethnicity. Of course, it's still a voluntary field. You don't have to report your race ethnicity when you get tested, but it became, I think that they issued a health advisory from the state secretary of health. I forget when it was. I think it was maybe in the fall, or I forget exactly. I can look up that information for you if you're interested. But a lot of it was push on the part of community stakeholders to have the state health department actually issue advisories to encourage reporting of that information. So yeah, in April of 2020, which was pretty early in the pandemic, it was pretty sparse. But by the time we started doing the analysis a few months later, it was a lot better.
Wonderful. Thank you.
Thanks so much for that question. I want to open it up to anyone. You can post your questions in the chat. You can raise your hand and I will unmute your mic. I also encourage people to, if you anticipate that you or your organization might use this data, share with us how you think that it would be helpful to you, to policymakers, to people in your community.
yeah, maybe if there are no questions coming up, I'm just curious about, I know some of you are students, some of you are also maybe implementing or working on specific projects. Have you come across similar challenges, right? We're talking about vulnerability and sort of like the disparities across races. And how are you dealing with some of this in some of your work? Are you finding that the data is available? Yeah, how are some of the solutions or even challenges or wish lists that you may have around this type of work?
I don't mean to take up the floor, but I guess while waiting for others to think on their experiences too, here at the Penn State College of Medicine, we have something called the Refugee Initiative, which is a student-run organization that has worked to help refugees in the central Pennsylvania area with mainly food insecurity. That was the primary purpose, but when the COVID-19 pandemic hit, the relationships we'd formed with these families were strong enough that they came to us with their concerns at the time, and so many of them had lost their jobs and needed help with unemployment assistance, and there were really scarce resources for learning to navigate that kind of system at the time. And it's the refugee resettlement agencies are too busy. Everyone was spread thin. So this is obviously a sub-minority population, right? This is, and I'm sure it's harder to collect data on populations like this. I know there are students at my school right now working with the Department of Health to try and create a refugee needs assessment to try fill that gap, but it's a slow work in progress. So I think projects like yours are good examples for what might be able to happen in the future.
Mm-hmm.
Yeah, thanks for sharing that. I think one thing I will note that one of the benefits of this tool and the live data that we were able to access was to kind of show where hotspots in terms of, I mean, we were looking at like COVID infections, like direct COVID outcomes, not so much the downstream social and economic impacts, but we could see where hotspots were emerging over the course of the pandemic. And in Allegheny County, we also found that refugee communities are particularly geographically isolated, and I think that's probably common in a lot of cities. So we could kind of see, like, as hotspots were emerging within those communities from the maps that we had presented, that was the case. So again, just kind of lobbying for the importance of regularly updated, geographically linked data and how that can really help to direct response. I know that testing providers locally use that information to, locate additional mobile testing facilities, partner with community organizations in those neighborhoods, and it was particularly useful from like an immediate action perspective.
One thing I was curious about, I know you mentioned vaccines at the very end of the presentation. Do you guys have plans to update the tracker with vaccine information and different data points surrounding that?
Yeah, great question. So we don't have immediate plans to do that. I think it would be super interesting. I will say that the vaccine data, I haven't looked at them recently, but they are even spottier in terms of the types of information on, characteristics of individuals and geographic tags and things like that than even the testing data are. So that would be one barrier, but I have been kind of tracking, the dashboards that are put out by the county and the state to take a look at that. I know the BEC has done some work on vaccine equity, and they've written a report. I think it's a couple of months old at this point, but on the fact that so much data are missing in terms of vaccine distribution by race and things like that. So our partners are doing more work on that, but we haven't made plans to specifically update the tracker.
Yeah, and I think so from the Sego Ventures side, as similar to this work around vulnerability for COVID-19 overall, we also did a lot of groundwork to build another index, which we're calling the COVID-19 Vaccine Access and Coverage Index. And what this does is that it specifically looks at both the demand and supply side of vaccines, and it looks at factors that would influence negative or present barriers to getting vaccine coverage as high as we want. So we've done work around that, and then we've also done work around vaccine archetypes or vaccine uptake archetypes or personas, where we look at the reasons, underlying reasons why people are not taking the vaccine. It could include costs or systemic barriers, but also a lot of sort of psychological and belief system type of reasons. So those are some of the build ups that we have, and that's sort of like our bread and butter, the work that we use to then go into a community and analyze it. So if we were to find granular enough data for vaccines at a particular juncture, then we can do similar work to this. But for this tool right now, it's kind of standing as it is.
Yeah, thank you. I was really excited to get to highlight this project to PPHA just because of the combination of like collaboration across different organizations, like providing open source data, kind of like with an emphasis on people really being able to use it. So thank you so much for coming on here and sharing this with us today. Yeah, it doesn't look like we have any more questions, so we can wrap things up for now. Yeah, thank you so much.
Great. Thank you, Brooke, and thank you everyone for joining.
Yeah, thanks so much for the opportunity to share, Brooke. This was great.
All right. Thank you both. Have a good afternoon, people.
Thank you.
Thanks.
Bye-bye.
Bye, everybody.